record. Okay. All right, how are you all doing this rainy afternoon? Can you hear me?
Yes.
Thank you. All right, so today we are going to be finishing the elbow, wrist, and hand. Couple reminders. Everyone is well aware, because you've been studying hard, everyone is well aware that we have our third lecture exam on Monday. I put a little thing on Moodle to give you information about it. So please, Monday, make sure, as always, that you are able to load your video so I can watch you. Monday, we will have only the exam starting at 2:30. There's no lecture afterwards. It covers 2 chapters, the shoulder and then the elbow, wrist, and hand. I'm thinking it's going to be about 45 questions, and I'm giving you 55 minutes to complete it. The format will be the same as you've always seen. Multiple choice, where you only have one correct answer, and then some short answer. All right, are there any questions, comments, thoughts on the upcoming exam? I guess the one good news is that there's less material, it being only 2 chapters. Questions, comments, thoughts? Are you alive? Can someone just remind me, say something, you're alive?
Yeah.
Okay. All righty. I also want to remind you that 1 week from today, we will not be having class, because I had something planned already that next Thursday before I was asked to teach this class. So next Thursday, 1 week from today, no class. Next week for lab, there's no lab where we're meeting in person. However, it's a great time to work on your lab project. I feel like I'm saying this every day now, right? Start working on it. Start working on it. Start working on it. Have some of you started to work on it? You can be honest.
No.
Yes.
Yeah,
I think once you get into it, there's a lot of detail. So I've built in this time, and it's there for you to use. I know it might be tempting to go to happy hour instead next Thursday afternoon. But even if you just spend an hour, something, you're going to be thankful later. Okay, so everyone's clear. I will see you next Monday for our lecture exam on Zoom. No lab. Thursday, next Thursday, no class at all. Lecture or lab. Are we good? All right. Okay, before we finish the wrist, elbow, wrist, and hand, I've put together a tentative schedule for your lab presentations. I said I would do that by today, and I've held up to my word. So as you know, in addition to preparing all those tables and doing a write-up for your final lab project, you are also going to be doing a short presentation in lab. If you look at the syllabus, the updated syllabus that I posted on Moodle, the last 2 weeks of lab are all student presentations. So I've put together a tentative list, and I'm going to share the screen and show you. Share screen. Okay, where is it? Here we go. Let's see if I can zoom this in a little bit. View, zoom. 125. Can you read that? I can zoom it in again. Whoa. So I've put you according to whether you're in Monday or Thursday lab. But two things. Because we have so many people in this course, I guess I'm just so good of a teacher, you all just wanted to sign up, right? Ha ha ha. We have so many people that I'm going to have to shorten your presentation. Originally, I had asked it to be 15 minutes. But we are going to shorten the lab presentation to 10 minutes. Everyone hear me? 10 minutes?
Yep.
Okay. So please make that change in your mind or write it down. Now, Thursday obviously has way more people in it. There's many more people in it. So I need some people. I need 5 people total. This is confusing. So let me just insert this so you don't see it. Okay. I am in search of 5 people in Thursday's lab who would be able and willing to come to a Monday lab. Just so the time works out. Can I get some volunteers? Is there anybody in either of these, anybody in a Thursday lab that is able to switch to a Monday? Either one, you can switch to this Monday or that Monday. I know some of you may not be able to because you may have something else in your schedule, but I'm hoping some of you can, because otherwise the timing isn't going to work.
Yeah, you should just shorten it to 5 minutes.
I'll second that.
It's not enough time. If I have to cut into another lab, I will. But I was hoping that some people might be able to switch to a Monday just once.
Professor, if be able to switch it with work and come in either on the 19th or the 26th. But can I reach out to you with an email?
Of course. So I'm gonna color you gray as a tentative. Just let me know.
I can do the 26th.
Gretchen. So we're gonna move you over here. I'm gonna put you in a different color so I'll remember that you're from Monday's or from Thursday's lab.
I can also move to Monday, the 26th.
Can I add, was that Shauna?
Yes. And Natalie said she can move to the 26th as well.
Yes.
Thank you. Let me see. Where's Shauna? Shauna, you said you could move to what date?
Monday, the 26th.
I can probably move to the 26th. I just have to talk to Dr. McCormick.
I don't want you to have to skip another class.
Oh, I just switched from Monday to Thursday. He has 2 sections.
Okay. Can't see who that was.
Alicia.
Alicia. And I forgot one of your L's, didn't I?
Nope, you got it right.
Is it just one L?
There's 1 L in my first name and 2 in my last name.
Yeah. Okay. Which Monday would you be able to switch to?
The 26th.
Okay. And I'm gonna put you as a gray.
The 26th can also work for me too. This is Natalie.
Natalie.
26 is Zoom, just like Zoom.
Hold on. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, I can fit one more person in there. Natalie. You right here. Nobody wants to come to Monday, the 19th, because it's too soon, huh? You get it over with.
I say the people that have it on the first Monday and the first Thursday should only have to present for 5 minutes. I think that evens it out.
I have no response to that. Plenty of time. That's why I'm giving you all these open lab periods. Plenty of time. Okay, so I'll just have to switch some of these. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we'll just switch this over here and we'll make it work. Okay. So this is my tentative list. I will post it on Moodle. If anybody else is interested from Thursday to switching to Monday, the 19th, get it over with, please let me know.
So is the day that we're presenting on the day that our whole entire project is due?
That is correct. But I'm doing this today early because I want you to have plenty of time. So that's basically a month. Plus the 2 hours next week that you'd be in lab, but you could work on it. I don't know, if it was me, I'd rather get it over with. That's just me.
Yeah, but I'd also like to have that extra week too.
I did this, I just tried to group them by activity type so they were similar. But everybody has plenty of time, over a month, or at least a month. All right. Okay, so I will post that on Moodle for you. Please start working on your final lab project. If you have questions, email me. Say if you have questions that can't be answered easily over email, we can set up a Zoom call. Remember, I'm going to grade those tables. I'm going to actually grade them. So you want to make sure that your joint motions are correct, that your muscle actions are correct. You can use what we've done in lab to help you. We're basically building everything that you need to do for your lab project in lab already. Okay. All right, anything else for the good of the order before we jump right in? Okay. All right, let me pull up. Let's see, we're going to save this to make sure I got that. And then we're going to pull up the elbow, wrist, and hand. Okay. All right, so we began this chapter last week, elbow, wrist, and hand. So exciting. The primary joint of the elbow is the humeral ulnar joint. What type of joint? What type of synovial joint is the humeral ulnar joint?
Hinge.
The hinge joint, right? So it can only do flexion and extension. This time, I'm asking you to make sure that you know the articulating surfaces. So the humeral ulnar joint is the joint between the olecranon. Hold on, let me say that again. The humeral ulnar joint is the joint between the trochlea of the humerus into the trochlear notch, or the end of the ice cream scoop of the ulna. What is the closed pack position of the elbow? Where is it have the most bone-to-bone contact and therefore the most stable?
Full extension.
Very good, full extension. We mentioned briefly the radial joint, not really a joint unless you are flexed, not really that significant. And then we talked about the proximal radial ulnar joint. What type of joint is the proximal radial ulnar joint? This is what does pronation, supination.
Pivot.
Right, so the joint up here is a pivot joint. Motions allowed are pronation and supination. Make sure you review the articulating surfaces of the proximal radial ulnar joint. Head of the radius fits into the radial notch of the ulna. What is the closed pack position of the proximal radial ulnar joint? Slightly pronated or slightly supinated?
Supinated.
Supinated. These things that I'm reviewing with you are really important. So they may be something I ask you next week on the test questions, right? We ended by talking about the carry angle, the fact that when someone is just standing with their arms at their side, the forearm has a slight lateral angle. What is a normal lateral angle in degrees for the carry angle for adults?
10 to 15 degrees.
10 to 15 degrees. Good, good, good. Okay, moving on. Here we go. So we're going to pick up where we left off. Now that we've talked about the bony structures of the elbow, in and around the elbow, let's mention some of the other structures. Of course, there's a joint capsule. You know, that's like the saran wrap. The joint capsule encapsulates all of those. So that joint capsule is going to encapsulate the radial ulnar joint, the humeral ulnar joint, and the proximal radial ulnar joint. Say that 3 times fast. So the joint capsule of the elbow covers all 3 joints we discussed. But the joint capsule itself is pretty weak. Pretty weak. At the very beginning of this chapter, we talked about what provides the most structure to the elbow joint, the humeral ulnar joint. In the shoulder, we rely most on the rotator cuff muscles. In the hip, we rely most on the bony structure. What do we rely most on in the humeral ulnar joint?
Bones and ligaments, but it's 50-50.
You should just be putting a star beside everything that I review. Test question, test question. So yes, in the elbow, it's about 50-50. We rely about half on the bony structure, and the other half we rely on ligaments. The joint capsule, it's there, but it's pretty weak. Let's talk about those ligaments, shall we? Can we? All right, let's share the screen here. I don't have my iPad with me today. I had a technical issue. So if you have a question, I cannot see the chat right now. Just chime in. Okay. Ligaments of the elbow. They are pretty strong. Basically, we have a medial collateral ligament or ulnar collateral ligament, and we have a lateral collateral or radial collateral ligament. It's much like the knee. I think the knee is easier for people to understand. There's a ligament on either side of the knee, right? One is your medial, one is your lateral. And ligaments that are on the sides of joints, we call collateral ligaments. So in the elbow, it's the same thing. We have a medial collateral ligament, also known as the ulnar collateral ligament. So you should know that. Ulnar collateral and medial collateral mean the same thing. So on the medial side, pinky side is the ulna. Therefore, ulnar collateral ligament is on the inside. And then the lateral collateral or radial collateral ligament is on the outside. This is a pretty decent picture. Ulnar collateral or medial collateral, lateral collateral or radial collateral. Okay. Which do you think is stronger, radial collateral or ulnar collateral?
Ulnar.
Indeed, the ulnar collateral ligament is stronger. So between the two, the ulnar collateral ligament is stronger. And the ulnar collateral ligament, it needs to be stronger because it is more prone to injury. This medial ligament is much more prone to injury versus the lateral ligament. Why is that?
Because more force is applied to it in flexion of the radial or humeral ulnar joint than the humeral radial joint.
Yeah, I think you're on the right track. It's very similar to the knee. If you think about the knee, the medial collateral is much more prone to injury. And the reason why in the knee, the MCL, medial collateral, and the reason why in the elbow that the medial or ulnar collateral is because it's much more likely to have a force upon it. And I'm going to explain that in a minute, but I just want to give you a moment to maybe write that down. So the ulnar or medial collateral ligament is stronger. It is more prone to injury because it's more likely to have forces on it. The ulnar collateral ligament is more likely to have forces placed upon it. Okay. I'm going to introduce some terms here, and I'd like you to know these. That's why I'm writing them down. Make it small and bigger. Have you heard of the terms a valgus force and a varus force? Has anyone heard of those before?
Somewhat.
Somewhat. So a valgus force is a force. How can I define this? A valgus force is a force from the outside. And I'm going to show you. And that means, by definition, that a varus force is a force from the inside.
I have a question. When you say outside, do you mean lateral compared to inside, meaning medial?
Yes, and I'm going to show you in a minute. So you might want to say outside lateral or inside medial. In the elbow, a valgus force will stress, a valgus force will apply stress on the ulnar collateral ligament. And I'm going to show you in a minute. Whereas a varus force applies stress to the radial collateral ligament. Now remember, the ulnar collateral ligament is the same thing as the medial collateral ligament, and the radial collateral ligament is the same thing as the lateral collateral ligament. So it's kind of opposite there. A valgus force is a lateral force. And by the way, sometimes people remember valgus as a lateral force because lateral begins with an L. And there's an L in valgus. So one way to remember that a valgus force is a lateral force is that because there's an L, which means a varus force is medial. But it's kind of opposite. So a valgus force is a lateral force, but it stresses the medial ligament. Versus a varus force is a medial force, but it stresses the lateral ligament. This is one of those cases where it'd be so much easier to be in person because I could have the model and I could show you. Okay. I'm gonna get up here. All right. So we have the elbow, right? Here's my elbow. It's the front of my elbow. A valgus force is a force from the outside. So you can see my body. Here's my elbow. A valgus is a force from the outside. So if a force comes in from the outside, you might get like if I get tackled from the outside, I might get a bruise here, but in terms of a ligament, a force from the outside will stretch the inside ligament. Does that make sense? So if I am bracing my hand and I get I'm wrestling in a wrestling match, and I get a force from here, if that force was strong enough, couldn't it stretch and tear this inside ligament? Does that make sense? A lateral force will stretch the inside ligament. So that's a common injury mechanism for the ulnar collateral or medial collateral ligament. Someone's wrestling or a football player falls and they get tackled on from the outside. And while you might get a bruise here, we're talking about ligaments. So a force from a valgus force or a force from the outside is going to stretch and potentially tear the medial ligament. Can I get some kind of feedback? Is anybody with me?
Yes.
Think about the knee, it's the same thing, you know? Think about any athlete that's torn their ACL. You know, the Tom Brady just open up a YouTube video. The medial collateral ligament and the ACL will be stretched and possibly torn from a lateral or valgus force. And I had asked you at the beginning, is it more common to injure the ulnar collateral or medial collateral? Excuse me, ulnar collateral or radial collateral? It's much more common to injure the ulnar collateral because it's much more common to have a valgus force. Just with our everyday activities, with how we may brace ourselves when we fall, because of sports, people are most often going to tackle us from the outside. So the ulnar collateral ligament is much more likely to be torn because it's much more likely to have a valgus force or a force from the outside, which will stretch and tear the inside ligament. Please ask questions if you have them. I mean, you may just be able to memorize one of these. Memorize the valgus. It's a force from the outside, it's a lateral force. Put stress on the medial or ulnar collateral ligament. Because if you know one, you're going to know the other. The other is just the opposite. A varus force is a force from the inside. Think about a varus force. It's even hard for me to pretend because you don't really have many varus forces. A varus force is a force from the inside, and it could stretch the outside ligament. But it's a much less common mechanism. And the good thing is, once you learn these terms, you're going to know them for the knee. Look at all these fun terms we're learning. Kinematics, kinetics, torque, valgus, varus. It's like the fun never ends. Okay, how do we feel about that?
Good.
If I don't have any questions, I'm gonna go on. Can't believe baseball starts in like 2 weeks. I think some of the stadiums are allowing like a 25% capacity. As you know, I'm an Orioles fan, so they came out and they said that Camden Yards is going to allow 25% capacity, but that's more fans than they usually have anyway. You have to worry about it. Okay, all right, good. Now, so I mentioned the radial collateral ligament. If you look more closely at the ulnar collateral ligament, it has several different bands or bundles. And I've listed them in your notes. There's an anterior band or bundle, posterior and transverse. All I want to point out is which of these is the strongest. The strongest of these three parts of the ulnar collateral ligament is the anterior bundle. This should be a great question next Monday. You're gonna kill it. Which of the following portion of the ulnar collateral ligament of the elbow is the strongest? And you're going to choose anterior bundle. You should know that there are 3 different parts to it. But then know that the anterior bundle is the strongest. And there's this fun ligament called the annular ligament. So we're talking about the elbow. We talked about the medial or ulnar collateral ligament. We talked about the radial or lateral collateral ligament. The last one is called the annular ligament. And the annular ligament simply runs from one side of the ulna to the other side of the ulna, because the annular ligament holds the head of the radius in place. So the annular ligament is a little bit below the actual elbow, a little bit distal to it. But the function of the annular ligament is just to hold the head of the radius in place. Remember, this is the proximal radial ulnar joint, and this is where the pivot takes place. So when you pronate and supinate, it's the radius moving over the ulna in that pivot joint. Well, we better have a ligament to hold that head of the radius in place as it pivots. So the annular ligament goes over top the head of the radius, and its function is to keep the head of the radius in place. Good. You can see on your notes there, I'm just making a note, make sure that you know that this interosseous membrane is there. We know in the forearm, the radius and ulna, the forearm bones are side by side. We know that the radius moves over the ulna when we pronate and supinate. But to help these bones be a little bit more stable, we have this connective tissue in between the radius and ulna. And it is called the interosseous membrane. Inter means between, osseous means bone. So it's a membrane between the two bones. Good, good, good. Last structure that's in and around this area is the ulnar nerve. So this is a pretty decent picture. We're looking at the medial aspect of the elbow. The yellow thing is the ulnar nerve. In lab on Monday, we palpated this. In lab today, you're going to palpate your own ulnar nerve. The way that you find it is that we palpate, and I've put little red X's here. The way we palpate it is we can palpate the olecranon process, the tip of the elbow, and then the medial epicondyle, the bone on the medial side. And when you palpate the olecranon process and medial epicondyle, right in the middle of those two is the groove where the ulnar nerve is. If you hit your funny bone, this is what you're hitting, and that's why it leads to some numbness and tingling going down your forearm. If someone tears their ulnar collateral ligament, surgery is made more difficult because of this nerve. Oftentimes they'll have to do what's called an ulnar nerve transposition. They'll have to pick up the ulnar nerve and move it to be able to work with the ligament. A lot of times people that have that ulnar collateral ligament surgery will have complications with this nerve because it's just right there. Okay, good. I want to see all your lovely faces. Your names. As always, my friends, make sure you sign in on the chat, please. All right. Ready to dazzle me with your knowledge of the wrist anatomy? The 8 carpal bones, scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. Come on. You can hear me, right? Am I especially annoying today? Is this why? Wow. I guess no answer means that I am. Sleepy. Someone's sleepy. No worries. Okay, I'm going to share the screen again. Let's do an anatomy review. So if we look at the wrist, we have a radiocarpal joint. Come on, folks. If you know the anatomy, the joints are named for the bones they connect. So radiocarpal is a joint between the radius and the carpal bones, particularly this first row. Particularly, the radiocarpal joint is a joint between the radius and the scaphoid and lunate. So these are the 2 carpal bones we're going to talk about, but make sure you jot those down. The radiocarpal joint is specifically a joint between the radius and our first 2 carpal bones, scaphoid and lunate. Joint between the radius and our first 2 carpal bones, scaphoid and lunate. This is a condyloid joint. This is the radiocarpal joint between the radius and the scaphoid and lunate is a condyloid joint. It has a nice concave surface on one end, convex surface on the other. When you think about your wrist, most of the motion of the wrist is happening here. You should know that. Most of our wrist motion, flexion, extension, ulnar, radial deviation, most of our wrist motion is happening at the radiocarpal joint. It is a condyloid joint and it can do the wrist motions, flexion, extension, ulnar deviation, radial deviation. This is the joint where most of the wrist motion happens. Condyloid joint. I'm going to tell you what the closed pack position is, but you don't need to know it for the exam. Hopefully everyone woke up when I said that. I'm going to tell you the closed pack position of the radio-ulnar joint, but you don't need to know it for the exam. If you're interested, the closed pack position of this joint is slight extension and radial deviation. Slight extension and radial deviation. But you don't need to know that for the exam.
Did you go over the articulating surfaces? Or
Just the bones. So just know that for the radio-ulnar joint, it is the joint between the radius and our first two carpal bones, the scaphoid and lunate. The radiocarpal joint is the joint between the radius and the scaphoid and lunate. That was the radiocarpal joint. Okay, we talked about the proximal radio-ulnar joint between the radius and ulnar. There is a distal radio-ulnar joint. That would be between the distal radius and ulna. But there's really not a lot of movement there, so we're not going to worry about it. So it does exist, the distal radio-ulnar joint, but there's not a lot of motion, so we're not going to worry about it. Okay, so we talked about the radiocarpal joint between the radius and scaphoid and lunate, and the radiocarpal joint is a condyloid joint. We already talked about that. Next on your list of joints is the intercarpal joints. Well, as the name suggests, intercarpal, between carpal bones. We have 8 bones of the wrist. And we can identify the intercarpal bones, the joints between each one of these 8 carpal bones. So we'll keep it simple. Intercarpal joints, joints between the carpal bones. What kind of joints are they? Drum roll, please. Gliding. So there's not necessarily motion we can see with our eyes, but these carpal bones, they glide a little bit. So the intercarpal joints are gliding. As such, as they're gliding joints, they can provide a little bit of gliding motion. But there's no flexion, extension, any of that, just gliding motion. Now, I hope you're awake because I am asking you to know the 8 carpal bones. It's time, ladies and gentlemen. 300 level course here, it's time. There are 8 carpal bones. There's many different sayings people can use to help remember them. The one that I've always learned and remembered 22 years now from when I first learned them. Some lovers try positions that they can't handle. Now, whether that's true or not, I don't know. I'm a nun and I'm celibate. That's not true. It's a tough crowd today. Have any of you heard that saying before? To remember these bones? Are you out there?
I have not heard that before.
The celibate nun wants to know if you're out there. Okay, that was one. I haven't heard it before. There's some other ones, but this one I think is the most fun. The way that this little mnemonic device works out is you start on the medial side. In lab this week, you're going to be palpating the anatomical snuff box. So my Monday peeps will know that. Right here, and I don't have a great one. Right here, if you kind of move your thumb back, there's like a little divot. We'll see it in lab today. That's called the anatomical snuff box. That's the starting point for how to name these bones. So it's thumb side. So we're going to name the bones in 2 rows, starting on the thumb side and starting proximal. So we're going to name scaphoid, lunate, triquetrium, pisiform, some lovers try positions. Then we go back for the second row. So it's 1, 2, 3, 4. Then we come back to the medial side, 5, 6, 7, 8. Some lovers try positions that they can't handle. Scaphoid, lunate, triquetrium, pisiform, trapezium, trapezoid, capitate, hamate. I had that backwards. I have these listed backwards. What am I doing? Trapezium, trapezoid. The way that I remember these two is that it's alphabetical order. Trapezium comes on the alphabet before trapezoid, because I comes before O. So I'm going to post this on Moodle. I'm also recording this lecture for some people that weren't able to make it. So plenty of ways for you to review. Here's a nice little X-ray that shows you scaphoid, lunate, triquetrium, pisiform, trapezium, trapezoid, capitate, hamate. Some lovers try positions that they can't handle. Starting on the thumb side by the radius. Okay. That's just memorization. I got to move on so we can get through our material. But if you have any questions, just please interrupt me. Okay, some other interesting pieces that are in and around the wrist, the carpal bones. There's this triangular fibrocartilage complex. What you see on your notes, I just called this a cartilaginous disc. You don't have to memorize triangular fibrocartilage complex, TFCC. I mean, you can if you want to, but you don't have to. All I'm pointing out is there is an additional piece of cartilage between the ulna and the lunate. Before we were talking about the radiocarpal, we were over here. Now I'm looking at the ulnar side, the pinky side. Well, between the ulna and the carpal bone that it articulates with, the ulna and the lunate, there's an extra wedge of cartilage. So here, if we magnify between the ulna and the lunate, if we magnify that, we see a little extra piece of cartilage. It is for shock absorption. So you'll see a pattern in some areas of the body. We have a little additional piece of cartilage. We saw it in the shoulder. We have the labrum, right? An additional piece of cartilage between the head of the humerus and the glenoid fossa. In the knee, we have an additional piece of cartilage called the meniscus. Here in the wrist, we have an additional piece of cartilage between the ulna and the lunate. If you want to sound really fancy, you can say, oh yes, the TFCC, triangular fibrocartilage complex. But just know it's a cartilaginous disc between the ulna and the lunate. Good. There are a bunch of ligaments between the carpal bones. You do not have to know them. I've listed some there for you, the volar, the radiocarpal, but you don't need to know them. I get no celebration. I don't get a little like party hat emoji that you can probably send. Yay, thank you. Just seeing if you're still alive out there. Okay, I do want to ask that you know there's a really thick piece of connective tissue called the flexor retinaculum. That's a pretty cool word, retinaculum. All it means is thick connective tissue. This is the palmar side of the hand. Palmar side. So where I'm rubbing underneath the skin is a really thick piece of connective tissue called the flexor retinaculum, this white connective tissue. It does blend in with some muscles, but it's a really thick piece of connective tissue on the palmar side of the hand and the wrist. What this does is it holds all these tendons in place. We have a bunch of tendons from these muscles coming up. So we just have this thick piece of connective tissue to hold down and protect, to hold down those tendons. Palmar side, thick band of connective tissue, holds tendons in place. Guess what? Underneath that, what is the name of that tunnel that is formed? Underneath the flexor retinaculum, there's a tunnel which all these tendons go through. What is that tunnel called?
The carpal tunnel.
Yeah. So underneath this is the carpal tunnel, where all of the tendons go between the flexor retinaculum and the carpal bones. So this is what forms the outer boundary of the carpal tunnel. Protects and holds down the tendons. Now, I mentioned this in lab on Monday. So we're going to be talking about these forearm muscles in lab. There's one forearm muscle on this side. So we have some anterior forearm muscles on the palmar side, and we have some posterior forearm muscles on the posterior side. Well, all of these anterior forearm muscles go underneath the flexor retinaculum. They go through the carpal tunnel, with the exception of one. I've circled, there's a muscle called the palmaris longus. And this is pointing to its tendon. The muscle belly is down here. The palmaris longus is the only muscle tendon that doesn't go through the carpal tunnel. I'd like you to know this. In lab, we did this on Monday. We'll do it right now. If you bring your, do it right now with me if you want. If you bring your pinky and thumb together and slightly flex, don't flex too far. Bring your pinky and thumb together, slightly flex. Can you see my one tendon that pops out? When you do that, you will see one tendon that's pronounced, and that's the palmaris longus. The only reason you can see it is because it doesn't go underneath the carpal tunnel. Bring together your thumb and index finger, slightly flex. You should see one tendon pop out. Can anybody see it?
Yes.
Now, if you can't see it, about 10 to 20% of the population doesn't have a palmaris longus. So if you don't see it, you're not an alien. Maybe you don't have one. If someone gets that Tommy John surgery, the ulnar collateral ligament reconstruction, one of the common tendons that they'll use to make a new ulnar collateral ligament is the palmaris longus because it's superficial, so it's easy to take out. Okay. Good. I'm going to move on here. Looking at the hand, I'm going to let you review the joints. And I've tried to make it easier for you on this PowerPoint that I'm going to post on Moodle later tonight. Make sure you review the carpometacarpal joints, joints between the carpals and the metacarpals. Please pay attention to what I'm about to say. At the thumb carpometacarpal joint is a saddle joint. We didn't really discuss this before, but if I was to give you a list, like a multiple choice question, the carpometacarpal joint at the thumb is a saddle joint. And you know that I can move my thumb around a lot. Carpometacarpal joint has a lot of motion. Carpometacarpal joint at the thumb or first digit is a saddle joint. The remaining carpometacarpal joints are gliding joints. So the remaining joints between the carpals and the metacarpals, they're gliding. You don't have the same motion that you do at the thumb. So the thumb carpometacarpal is a saddle joint. The remaining 2 through 5 are gliding joints. Because remember, we named it from the first digit. So first digit is thumb, digit 2, 3, 4, 5. Then make sure you review the metacarpophalangeal joints. These are what you commonly think of as your knuckles, but the name tells us what it is, metacarpophalangeal. Your phalanges are your fingers. These are the metacarpals. So the metacarpophalangeal joint is the MCP. These are condyloid joints, all of them. Don't say knuckle on the exam or I'm going to have to punch it with my knuckles. Joking. This is a mini ball and socket. Think about, you can do pretty much everything that you can here than you can at the shoulder. I can flex, extend, I can adduct, and I can circumduct. Woo. So your metacarpophalangeal or knuckles are condyloid joints, mini ball and socket. Good, good, good. Moving quickly because this is straight recall. We have your interphalangeal joints. So we have a proximal interphalangeal joint, PIP, and a distal interphalangeal joint. What type of joint do you think these are? Just think about this joint. This is my proximal interphalangeal, and this is my distal interphalangeal. What type of joint do you think that is?
Hinge?
It's a hinge joint. So both of the interphalangeals, the proximal interphalangeal and the distal interphalangeal, are considered hinge joints, which means they can only flex or extend. Flex or extend. I mean, the distal interphalangeal joints are so cute. Boop, 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 boop. I would like you to know the closed pack position of our interphalangeal joints. And that is extension. So our interphalangeal joints are most stable in extension.
Professor, could you go back the metacarpal phalangeal joint? What was the movements that were allowed for that?
Well, it's a condyloid or mini ball and socket. So it can do flexion extension. It can do adduction, abduction, and it can do circumduction. Flexion extension, abduction, adduction, circumduction.
All right, thank you.
Sure. Flexion extension, adduction, abduction, circumduction. With the interphalangeal joints, I've introduced proximal and distal. I want to point out that the thumb doesn't have two. The thumb, we have a metacarpal phalangeal joint, but then we only have a distal interphalangeal. So digits 2 through 5 have both a proximal interphalangeal joint and a distal interphalangeal joint. But the thumb only has one interphalangeal joint. It's considered to be a distal interphalangeal joint. Thumb only has a distal interphalangeal joint. Okay. I have a quick note there about ligaments. So if we're looking at the the proximal interphalangeal joint and the distal interphalangeal joint, they have tiny little medial collateral ligaments and lateral collateral ligaments. I'm not going to ask you those, but I am pointing it out just for FYI. Won't be on the test, but you may not think of these joints as needing ligaments, but they're synovial joints. They need ligaments. So they have a tiny little medial collateral ligament and then a tiny little lateral collateral ligament. Okay. I always include these range of motion values, but you do not need to know them for the test. Got it? The energy today, blowing me away. Okay, in lab this week is where we're going to spend most of our time with the muscles. So I'm going to breeze through these and point out only a couple things. You know, I had a question earlier about the best way to study the muscles. And because I think from my experience, people tend to miss some questions on the muscles. You know, one of the best ways I would think to study the muscles is to just list the muscles and be able to give one action for each. Anterior deltoid, shoulder flexion. Middle deltoid, shoulder abduction. posterior deltoid, shoulder extension. Biceps brachii, elbow flexion. Triceps brachii, elbow extension. Serratus anterior, scapular protraction. Rhomboid, scapular retraction. So if you can give one action for each muscle. In addition to that, there's some muscles that we talk a little bit more about. So for example, from the shoulder chapter, I made a point of talking about the latissimus dorsi. Remember I said it was the handcuff muscle? So for some muscles that I take the time to point something out, you may need to know more than one action. So for the latissimus dorsi, I want you to know all three actions: shoulder extension, adduction, internal rotation. Does that make sense? Trying to help you here.
Can you repeat those, please?
For the latissimus dorsi,
Yes, please.
shoulder extension, shoulder adduction, shoulder extension, shoulder adduction, shoulder internal rotation.
Thank you.
Okay, so let's talk about the muscles of the elbow and forearm. You know the biceps brachii, the triceps brachii. I want to point out, and again, these are the things that you want to make a little note. The biceps brachii has two heads. That's why it's called biceps. Bi means two. There's a short head and a long head. Biceps brachii has two heads. In addition to doing elbow flexion, the biceps brachii does forearm supination. So I'd like you to know two actions for the biceps brachii: elbow flexion, biceps brachii, elbow flexion, forearm supination. Good. For the triceps, the reason it's called the triceps brachii is because it has three heads: long, lateral, and medial. Big muscle complex. Triceps brachii is called triceps because it has three heads: long, lateral, medial. And of course, the triceps brachii does elbow extension. In lab this week, some of you have had it, some of you haven't. We listed a muscle that does pronation and supination. So just review that. In lab, we listed the muscles on the anterior side of the forearm, or the flexors, and we listed the muscles on the posterior side of the forearm, the extensors. All the muscles on the anterior forearm do wrist flexion. Cover this in lab. All the muscles on the posterior side of the forearm do wrist extension. Same thing in the lab. We covered the muscles, or we will cover the muscles that do wrist ulnar deviation and wrist radial deviation. So study those labs. Be able to give one muscle, or be able to give one action for each muscle. Flexor carpi radialis flexes the wrist. Extensor carpi ulnaris extends the wrist. Flexor carpi radialis also does radial deviation, but we list these in lab. There are a bunch of intrinsic hand muscles, but you don't need to know them. You don't need to know any of the intrinsic hand muscles. Study your muscles, my friends. Be able to give one action. Look, I'm not even asking you for the origin and insertion or innervation. If that was really mean, I would ask you to memorize not only the action, but the origin, the insertion, and the innervation. Do you have to do that for any of your other classes? Memorize the origin and insertion?
In anatomy, we had to.
Okay, so the last part of this chapter, we'll talk about loads and torque and a little bit about injuries. Just like I did with the shoulder, I'm going to put in red what you need to know. It's never going to be a specific number, but just like basic concepts. Just like we did at the shoulder, be able to give an example of each of these types of loads at the elbow. So a compressive load on the elbow could be like a boxing punch. Wouldn't that put the bones of the elbows together? The elbow is not usually weight bearing, but it could be like a handstand. Wouldn't that put compression on the elbow? So be able to give an example of an activity that is a compressive force on the elbow. Be able to give an example of what might be a tension force that pulls the bones apart. Releasing a ball, that's going to have a tension force. If someone pulls your arm, so if the guy wrestling in red pulls on the arm of the blue dude, isn't that a tension force at the elbow? A shear force will be very similar to the examples we gave for the shoulder. So a rotation force, the discus, the cocking phase of a baseball pitch. And then be able to give a combined example, a baseball pitch, a lacrosse throw, a golf swing. These are all activities that combine different forces on the elbow, sometimes compression, sometimes shear. I put these in red, my friends. In which phase of the baseball pitch is the most force produced at the elbow? This is going to be different than the shoulder. Who can remind us? In what phase of the baseball pitch was there the most force produced at the shoulder?
Decelerate.
In the shoulder, we had the most force during deceleration. In the elbow, we have the most force or load during acceleration. There's different ways to look at it, so you might see this number and get a little confused. But in terms of load on the ligaments, which is what we really worry about, the acceleration phase. Different from the shoulder, which was the deceleration phase, but the elbow takes more of a force during the acceleration when you're cocking back. In which phase is the most torque produced at the shoulder? Elbow, excuse me. Again, this is different than the shoulder. In what phase is the most torque produced? The cocking phase. The cocking phase is when you come back, and the acceleration phase is when you come forward. So we have the most torque at the elbow during the cocking phase. We have the most force during the acceleration phase. I'm writing this in red, so I can't be, so I'm trying to be really clear. Based on this, excuse me. Based on this, which phases do you think are the most stressful to the elbow? Acceleration and cocking. You don't need to know the numbers for the force and the torque. But in this one example, know which phase has the most. And I'm going to post this on Moodle for you. Something else I want to point out, and you'll see it's in red. When we're talking about torque, which we have the greatest amount of torque on the elbow during the cocking phase, it is the anterior band of the ulnar collateral ligament that takes the most of that torque, which shouldn't be surprising because which was the strongest band? Anterior. So I'm putting in red the most important things to know. I have some information here about Tommy John surgery. This is all extra. In case you're wondering, this is named for Tommy John, the former Dodger pitcher, who really was the first well-known pitcher to have his ulnar collateral ligament reconstructed. Many, many pitchers have had it since. All extra. I got some more Philly information that I saw from the conference, but as we discussed before, I may have to rethink some of that. This is all extra. This is interesting, but it's extra. According to the Phillies, not the best source of information, the biggest risk factor for developing an ulnar collateral ligament injury was pitchers that pitched at a higher velocity and those that pitched year round, but not on the test. Okay. All extra, all extra. The last thing I want to talk about, and we mentioned this before, was the baseball pitch versus the football throw. Which motion produces more force and torque? Baseball or football throw?
Baseball.
Yeah. So by far, the baseball throw is much more stressful to the shoulder and elbow. I give you some information here. I even give you some numbers. You do not need to know these numbers. Just know which phase is more stressful, more load and more torque. Not which phase, which activity. It's baseball pitch. These are some differences between the football and the baseball throw. You do not need to know them. At the end, there are a couple, oh, before I do that, in your notes, you see active insufficiency. We're discussing that in lab, but make sure you review. So make sure you wrote down that definition from lab. Active insufficiency. The rest here, you know what a dislocation is. We already talked about the ulnar collateral ligament being more commonly damaged than the radial collateral ligament. I want to talk about one more thing that I'll mention in lab. I know it's 3:50. Give me 30 more seconds. Last thing I want to talk about is the scaphoid bone. I mentioned this in lab on Monday. I'll do it again today. Of your carpal bones, the one fracture that you really need to worry about is the scaphoid bone. That's the first carpal bone in the snuff box. And the reason why we worry about that is because it has a poor blood supply. But I discussed that in lab, just review. Of all the carpal bones, if you fracture the scaphoid, that's the most worrisome because it has a poor blood supply.
What is the treatment?
Be in a cast for longer. It can heal, but it's just, other bones heal so well. This one just doesn't heal so well, so you'll be in a cast for like 6 weeks. All right, I'll stick around if you have questions. Thanks for staying a minute late. If you have questions between now and Monday, send me an email. Send me an email to go on Zoom, whatever you need.
Hey, Professor, you're gonna send me,
This is John.
Yes,
Okay, great. Can I do the 10 o'clock again on Monday?
yeah, same time.
Yeah, can I? That'd be great.
Let me just make sure. It should be fine, but let me check my planner.
Okay.
I'm old school. I have one that I write things in. I can't use my phone.
I don't blame you. It's easier. The old
Monday
ways
at 10
die hard.
Monday at 10 a.m. is great.
Great. Thank you so much.
Have a good time tonight, okay?
Oh, yeah, in the rain. Thanks. Have a good night.
You too.